We're going to be talking about health records today. This is our last chapter in this module, and so I know everybody's ready to move to a new book and just get started on something a little bit different. So there are quite a few slides, and a lot of this information some of you already know, so I just want you to bear with me and use it as a review. I do want to point out that there are some great vocabulary words, and you're going to have workbook work to do the vocabulary words, but I wanted to point out a few that you need to pay extra close attention to, and it's compliance, subjective information, objective information, quality control, and tickler file. Now that doesn't mean that they're all not important, but those are the ones I want you to pay particular attention to. All right, so let's get started on our slides. I'm going to share our screen. Now keep in mind, I'm going to be reading some notes for some of the slides, so I may not be reading the slide exactly. So Healthcare Records, Chapter 12. These are the objectives we're going to be discussing. Okay, so let's talk about the types of records. There are two different formats. There's electronic. Some of the advantages of electronic is multiple users can access the record at the same time, and they're actually more accurate or have fewer errors. So some advantages or disadvantages of paper is they're less efficient. So of course that's a disadvantage. Good for evidence of patient care, and they're not nearly as useful in other capacities. It's important for the medical assistant to be versatile and knowledgeable about both systems. Okay, one of the things that I want to point out about electronic health records is most healthcare facilities have switched to electronic health records, or EHRs, and the federal government has also offered financial incentives for providers to implement EHRs. So let's talk about the importance of accurate medical records. So the provider enters notes about the patient's examination and any test results into the medical record. These notes serve as pieces of a jigsaw puzzle to help the provider make an accurate diagnosis and treatment plan. The medical record provides a complete history of all the care given to the patient, and an accurate medical record is the foundation for a legal defense in cases of medical professional liability. And also the information in the medical record supports claims for reimbursement and is required by most third-party payers. So one of the biggest things that I want you to pay attention to is that accurate medical records saves lives, because accuracy makes sure that your patient is going to get the correct care and the best care there is. And also medical records can provide legal protection to those who provide care to the patient. So they can be used as legal records. So let's talk about some contents of the health record. So there's subjective information, and these things can be personal demographics, past health, family, and social history, and the patient's chief complaint. Objective information, vital signs, and anthropometric measurements, findings in laboratory and radiology reports, diagnoses, treatment and prescribed and progress notes, condition at the time of treatment. The reason I got a little jumbled up is because I was looking for some extra notes that I made on this, and give me just a second. Okay, so subjective information is information that's actually provided by the patient. Some examples of subjective information is your patient's address, social security number, insurance information, and description of what the patient is feeling. So the subjective information is provided by the patient. Objective information is information through the provider's questions and observations made during the examination. So that is a good way to help remember. Subjective is what the patient's providing, and objective is what the doctor observes during the examination or questions that's being asked. Sorry about that. I was trying to not mess up my slide while I was actually looking for that extra information that I wrote down. So let's talk about personal demographics. What are found in personal demographics? Well, your patient's full name, and it needs to be spelled correctly. Names of parents or guardians, patient's gender, date of birth, marital status and the name of the spouse, home address, telephone number and email, occupation, name of employer, business address, phone number, employment information for spouse, healthcare insurance information, source of referral, and social security number. So I just want to say something really quickly. If you misspell your patient's name, because it's different than what's going to be on the insurance card, they're going to match that up when you send in your claim, and they're going to reject it. They're going to say, we don't know who that is. If you transpose an I and an E or what have you. Also, you need to make sure your patient's gender. I want to tell you a quick story about this. I had a claim, and I have to tell you, it was when I was pretty new and I was working a denial for a patient, and it wasn't a significant amount, but it was my job to get it paid. And guys, I looked and double checked, and I could not find what was wrong. Why won't they pay this? Well, it's because I had the patient listed as a male and they were female. Well, I didn't have them listed that way, but whoever put the demographics in gave the wrong gender. So when the claim was sent to the insurance company, because I was saying that the our records indicated that this patient was actually male when they were female. So that's why those things are important. I'm sorry, I bumped my mouse. So that's why it's so important that your personal demographics are accurate and on point. Past health, family, and social history. I do know that we have some of us have already gone over this, but we're just going to make quick work of it. The past health history will include information about previous illnesses and injuries. The patient's family history comprises the physical condition of the various members of the patient's family and any illness or disease individual members may have had, and a record of the causes of death. The social history includes information about the patient's lifestyle. So patient's chief complaint, or CC, would include concise account of the patient's symptoms in the patient's own words, and it includes all of those things. You guys can pause and read through all of that, but we're just going to keep going. I do want to say one thing first. Most medical facilities use a pain scale to determine the severity of the patient's discomfort. Do you guys remember sitting maybe in the hospital room or even in the doctor's office, and they have that, it looks like little smiley face emojis, and it goes all the way to the crying one, and they tell you, you know, how are you feeling, especially for kids. So let's talk more about objective information, findings that can be observed, vital signs, anthropometric measurements, findings in laboratory and radiology reports, diagnoses, treatment, prescribed, progress notes, condition at the time of termination of the treatment. So let's talk a little bit about the medical assistant's role. Care must be taken to ensure the patient's answers are not heard by others because they have a right to privacy, right? HIPAA. If the record is electronic, the patient may access the record through a patient's portal and document the information directly into the EHR system. The medical assistant may document the chief complaint, but the provider will question the patient in more detail. So who owns the health record? The provider or the medical facility, the maker, owns the physical record. The patient has a right to access the information, but does not own the physical record. So the actual paper health record should never leave the medical facility where it originated. Patients' records should be kept in a locked room or locked filing cabinets when the office is closed. EHRs eliminate the issue of legibility in the record, but it is just as important to be sure that all patient care is documented in the electronic health record. Also, according to HIPAA, the patient has a right to demand confidentiality. So if they sign or they don't sign a release form, you can't send their bills to the third-party payer. They have to pay it themselves. That's why you have to get that release of information form signed. Technologic terms in health information. Some confusion has arisen regarding the acronyms EMR and EMR and EHR. The electronic health record, EHR, is an electronic record and health-related information about a patient that confirms to nationally recognized interoperability standards and that can be created, managed, and consulted by authorized clinicians and staff from more than one healthcare organization. So you see that where it's italicized, for more than one healthcare organization? Well, I'm going to read you a little bit more that I found. I did a study of EMR versus EHR. So this is what I came up with EHR. These are my points for EHR, electronic health record. It is a snapshot that enables multiple providers to access the patient's overall health record. It can be shared electronically to different healthcare providers, and it makes it easy to keep a patient's record updated with information when they are working with several healthcare providers. So that was my EHR. So let's talk about EMR. I'm going to read what's on the slide, and then I'm going to tell you what I came up with. The electronic medical record, EMR, is an electronic record of health-related information about a patient that can be created, managed, and consulted by authorized clinicians and staff within a single healthcare organization. So do you see that italicized? So EMR is within a single healthcare organization. EHR is from more than one healthcare organization. Okay, so this is points that I came up with on my own for EMR. Primarily concerned with the medical treatment provided by one practice. Are important because they help practitioners and office staff record and keep track of a patient's progress or changes over time. A benefit is that it makes it easier to identify which patients are due for screening and preventative checkups. And I wrote this in big letters. An EMR remains in the office. It doesn't travel. So an EMR, an electronic medical record, is within a single healthcare organization. And EHR, it can go from more than one healthcare organization to another. They can go from organization to organization to organization. So an EHR can travel and an EMR cannot. So I hope that clears those two terms up for you. So let's talk about PHR, personal health record. is an electronic record of health-related information about an individual that conforms to nationally recognized interoperability standards that can be drawn from multiple sources, but that is managed, shared, and controlled by the individual. HIPAA uses the term PHI, or protected health information, which is any information about the health status, the provision of health care, or the payment for health care that can be linked to an individual patient. So we're going to talk about the HITECH Act and meaningful use. Okay, I really want you to pay close attention to this portion of your book. Highlight, make notes, and you can even make notes from this actual slide. So the HITECH Act provides financial incentives for meaningful use of certified EHR technology to achieve health and efficiency goals. It was incorporated into the ARRA to promote adoption and meaningful use of health information technology. HIPAA was created partly to simplify administrative processes using electronic devices, and meaningful use means providers must show that they are using the EHR technology in ways that can be measured significantly in quality and in quantity. So I'm going to go to my notes because I know that I made some detailed notes here. So first of all, I want to tell you that ARRA is the American Recovery and Reimbursement Act. And I'm going to tell you on what page you can find that on. Let me find my other note. Guys, I have notes everywhere. I really enjoyed studying this portion of things. Okay, so the 13th edition, it's on page 203. And in the 14th edition, it's page 246. So make sure that you go through and you make detailed notes on HITECH, the ARRA, and meaningful use. Three main components of meaningful use. Use of certified EHR in a meaningful manner, such as e-prescribing. The use of certified EHR technology for electronic exchange of health information to improve quality of healthcare, and use of certified EHR technology to submit clinical quality reports and other measures. Capabilities of EHR systems. So specialty software, it can be tailored terminology and patient care to providers' specialty. I was going to say it can be tailor-made, and then I said maybe I better read what it says and then go back. Specialty software is just that, it's specialty. It can be tailor-made for the facility and the physician. EHRs have an appointment scheduler, which makes it very easy for scheduling. It has appointment reminder and confirmation. It does automated calls to patients. And it has a prescription writer, produces electronic prescriptions for printing or submissions to the pharmacy. I don't know if you guys can remember or if you were even alive during this time, but I can remember when you had to take a copy of your prescription to the pharmacy and wait. Now it's all computerized, but I can remember the in-between time where they actually faxed it. So the EHR e-scribing is really convenient. Capabilities of the EHR system is also medical billing system. It manages all billing and accounting. It captures charges. Eligibility verification, which means it verifies insurance eligibility and demographic data online. And it has referral management, coordinates and shares information between current and referring providers. And laboratory order integration, it allows interaction with outside laboratories to order tests or check results. And it also has a patient portal, which allows the patients to access medical records, set up appointments, review a statement, and complete new patient records. I find as I go through, as I get a little bit older, I do use my patient portals now. For a long time, I didn't. I was like, oh, I don't want to do that. But I find it so much easier than having to call and make an appointment. And I love being able to look at what's available and choose my own time. I feel like I'm interrupting the receptionist. We know their phone is ringing, there's patients coming in. And so now I love my patient portals. Maintaining a connection with the patient when using the well, it's supposed to be the EHR, but do you guys see that PowerPoint slide says her, but it's EHR. Patients are consumers of healthcare services and expect quality. Use eye contact when using your EHR. Allow screen to be in view so that they feel part of the process, and position yourselves next to or at an angle to patient to encourage partnership. The patient may decide to change providers simply because he or she does not feel comfortable with that particular provider. When using the EHR, make sure nonverbal communication sends the right message to the patient. Okay, now let me clarify. Obviously, when you're making appointments or you're taking a payment, they're saying this for a medical assistant who is actually in the room with the patient. So I wanted to keep this slide in and give you further explanation. If you're actually on the computer looking something up for the patient, or you're putting their payment in, or whatever it is, make sure that you're using your nonverbal communication, making eye contact, smiling, still having conversation, but light conversation because you have a job to do. You just don't want them to feel ignored. You want them to feel like you care that they're there and that you're working for them. Okay, so we're going to continue on. Here's some these are a second set of learning objectives that we're going to go through, and these are actually listed at the beginning of your chapter of your book. So we're actually going to talk about backup systems in the EHR. So we have had perfect examples of why we have to have backup systems in place lately. You know, we've had 2 hurricanes. So what happens when we lose power? If a natural disaster occurs, the provider's office is without electricity for several days or even weeks. The provider must have a backup system for the EHR so that the office can still function. HIPAA requires that facilities adopt a backup and recovery plan that includes daily off-site software backup for the EHR system in the case of long-term power loss, and several alternatives can be used for data preservation and backup. So I want to actually pull up, I'm going to look in my notes because there was something. Okay, this is what I want to read. So this was something that I found very interesting and that I didn't necessarily know. It says EHR systems can be set up to automatically back up information at specific times during the day. This means only a minimum amount of information would be lost if the power went out. So I found that extremely interesting that you can actually set this up to where, you know, like every 2 hours, it backs up everything you've done within those 2 hours. So I just wanted to add that from my notes that I made. So alternatives for data backup: external hard drive, full server backup, and online backup systems. An external hard drive connects to the main computer and with fairly simple programming can copy the information in the EHR daily. The provider may want to back up the EHR system on a dedicated server, which is a large capacity computer set aside specifically for the EHR system. An online backup system can be used usually for a subscription fee. And medical assistants should keep their paper medical records skills sharp in case the EHR system is down for an extended period. So we're going to talk about something that is very, very important: retention and destruction of EHRs, electronic health records. In most offices, medical offices, records are classified in 3 ways: active, inactive, or closed. I want to give you a little bit of information here. If you have a pen and a piece of paper, you may want to write it down. Or no, you want to write it down. The process of moving a file from active to inactive is called purging. This question is on your NCCT exam. An EHR system can be set up to automatically move the inactive records to another server so that processing time will not be slowed down. Okay, so retention and destruction of EHRs continued here. Providers have an obligation to retain patient records, whether the paper or electronic. There is no current nationwide standard rule for establishing a records retention schedule. Records of any patient covered by Medicare or Medicaid must be kept for at least 10 years. And before old records are discarded, patients must be given the opportunity to claim a copy of records or have them sent elsewhere. So I want to make a point also: when there's no rule specifically, the best course is to keep the records for 10 years. So let's talk about the releasing of healthcare record information. Requests for medical information should be made in writing. Electronic signatures may be accepted as long as they are obtained with proper process controls. Most offices charge a fee to print or copy health records, and you need to pay particularly close attention to records release requests involving minors. HIPAA has HIPAA has designated that specific information must be included on the release of information form. Who is releasing the information? To whom the information is being released? What specific information is to be released? And an expiration date for the release. A staff member should always remain with the patient who is looking at his or her health record. When a release is presented to the office, copy only the records requested in that release. If there are any questions about what needs to be released, consult the office manager or the provider. So let's talk about HIES, Health Information Exchanges. A direct exchange is the ability to send and receive secure information electronically between care providers to support coordination of care. The demand for electronic health information exchange from one healthcare facility to another, together with nationwide effort to improve quality efficient of healthcare, is creating a demand for HIES. Currently, there are 3 forms: direct exchange, query-based exchange, and consumer-mediated exchange. So I already read the direct exchange is the ability to send and receive secure information electronically between care providers to support coordinated care. A query-based exchange is the ability for providers to find and or request information on a patient from other providers, often used for unplanned care. And a consumer-mediated exchange is the ability for patients to aggregate and control the use of their health information among providers. So that's the definition of those 3 forms. So now we have source-oriented records. Observations and data cataloged according to their source. Forms and progress notes filed in reverse chronological order, separate sections of record. Okay, so now I'm going to just give more words to that. The traditional patient record is source-oriented. That is, observations and data are entered by the provider, laboratory, radiology department, nurse, technician, and others, with no recording of a logical relationship among them. Some files may be included in chronological order. However, most patient files are in reverse chronological order so that the provider and the staff members do not have to search to the bottom of the chart to find a recent laboratory report on a test. They're in reverse chronological order, which means the most recent will be on top. So POR, problem-oriented records, divides records into 4 bases: database, problem list, treatment plan, and progress notes. The problem-oriented record is a departure from the traditional system of keeping patient records and divides medical attention into 4 components. The database includes the chief complaint, present illness, patient profile, review of systems, physical examination, and laboratory reports. The problem list is a numbered, titled list of every problem the patient has that requires management or workup. This may include social and demographic troubles in addition to strictly medical or surgical ones. The treatment plan includes management, additional workups needed, and therapy. Each plan is titled and numbered with respect to the problem. The progress notes include structured notes that are numbered to correspond with each problem number. The POR has the advantage of imposing order and organization on the information added to a patient's record. Okay, so now we're going to talk about SOAP notes. SOAP notes are subjective impressions, objective, which is clinical evidence, assessment or a diagnosis is A, and P, plans for further studies, treatment, or management. Progress notes follow the SOAP note approach. Some medical offices use an E in the record to represent evaluation. Others include E for education or R for response. The SOAP method forces a rational approach to the patient's problems and assists the formulation of a logical, orderly plan of patient care. The SOAP method often is used in the POR. What is POR? Problem-oriented records. So let's talk about documenting in the EHR. So use radio buttons, drop-down menus, and free text boxes. It is important to carefully review the choices made. Information documented using the free text boxes should be proofread before submitting. Okay, so a lot of you have already been through SIMS charting. Some of you have not, but you're going to learn a lot about the drop-down menus and radio buttons and free text boxes. But we're in the age of technology, so I think that we really pretty much know about these things because we're all on computers all the time. Documenting in a paper health record. Entry will always start with a date in the MMDDYYY format, followed by time. Okay, I think we're adjusted to that because we fill out lots of forms, and so that's a great thing to remember though. All entries must be written in black or blue ink. Documentation should be in the order in which the steps were completed. Making corrections and alterations to the health record. Okay, so correcting a handwritten entry. You draw a line through the error, insert the correction above or immediately after the error in a spot where it can be read clearly. If indicated by the policy and procedures manual, write error or ERR in the margin. and the person making the correction should write his or her initials or signature below the correction and the date. Please do not use whiteout on medical records. You cannot do that. No whiteout, none. One line, the correction, your initials, or whatever your policy is for your facility. So dictation and transcription. So transcription can be done from written notes, such as shorthand, or machine dictation using machine transcription unit or portable transcription unit. The system is accessed by the telephone. Sorry, guys. Accuracy and speed are primary requisites, and voice recognition software may also be used. Medical transcription is really not as popular as it used to be because a lot of EHRs come with a voice recognition software. Filing equipment. Okay, guys, I know that you may say, I know how to file, but I just want to talk to you about how it must be so very organized. You have to make sure that you're putting everything in a proper file. You have to make sure that you're putting your files away. You have to be organized and orderly. So here are some filing equipment: drawer files, horizontal shelf files, rotary circular files, compactable files, automated files, and card files. Now you're going to see pictures of all of those in your textbook. So just take a moment while you're reading your text and really get to know the different filing systems. Filing supplies. You're going to have divider guides, out guides, file folders, and labels. Each file drawer or shelf should be equipped with plenty of dividers or guides. The label is a necessary filing and finding device. Use labels to identify each shelf, drawer, divider guide, and folder. So you guys know that we actually spend a lot of time tabbing our manuals and organizing our manuals and organizing our information. It's all part of the skill that when you start in your medical facilities, Katrina can tell you guys, she has got to know how to file. She's got to be organized. In order to be successful, you must be accurate, organized, and on task. Indexing rules. Last names considered first in filing, first name considered second, and the middle name or initial is considered the third. Initials precede a name beginning with the same letter. Hyphenated elements considered one unit. Apostrophe disregarded in filing. Indistinguishable foreign names. Prefixes considered part of a name. Okay, so let me go back to indistinguishable foreign names. I'm going to read on that. When indexing a foreign name in which you cannot distinguish between the first and the last names, index each part of the name in the order in which it is written. If you can make that distinction, use the last name as the first indexing unit. So after that, the indexing rules to continue on. Abbreviated parts are indexed as written. MAC and MC are filed in their regular place in the alphabet. The name of a married woman is indexed by her legal name. Titles may be used as the last filing unit if needed. Degrees used only to distinguish from identical name. Articles, for example, VA, are disregarded in indexing. The files have a great many names beginning with MAC or MC. Some offices file them as separate letter of the alphabet for convenience. So, filing method. The most common and the simplest form is alphabetically. But some of the drawbacks of the alphabetic system is correct spelling of the name must be known. As the number of files increases, more space is needed for each section of the alphabet. This results in periodic shifting of folders to allow expansion. And as files expand, more time is required for filing or retrieving each folder because of the greater number of folders involved in the search. The time can be greatly reduced by color coding. Then there's the direct filing system. Requires only a file cabinet or shelf folders and divider guides. Oh, I'm sorry, that's all about, okay. Let's start over. Sorry, guys. Somebody knocked on my door and it got me miscarbureted on this slide. But we're going to say that was practice. This is the real thing. So Alphabetic is the most simple and commonly used filing system. It requires only a filing cabinet or shelf folders and dividers. And then I read the drawbacks. You have to know the correct spelling of names. As the number of files increase, more space is needed for each section. And as files expand, more and more time is required for filing and retrieving. And those are your drawbacks. I do apologize for that. Okay, so let's talk about numeric filing. Some form of numeric filing combined with color and shelf filing is used by practically every large clinic or hospital. Several types of numeric filing systems can be used, including the straight or consecutive numeric system. Patients are given consecutive numbers as they visit the practice. The terminal digit system, or use of the last 4 digits of a patient's social security number. It requires more training, but fewer errors occur with this particular filing system. So other filing systems, you have subject filing and color coding, which a specific color is selected to identify each letter of the alphabet. Alphabetic color coding, numeric color coding, and other color coding applications. So let's talk about organization of files. So let's talk about correspondence. Pertaining to patients, medical records should be filed with the case history. Other medical correspondence should be filed in subject file. Correspondence of a general nature pertaining to the operation of the office is part of the business side of the practice. The most active financial record is the patient's ledger. In facilities that still use a manual system, this is a card or vertical tray file, and the accounts are arranged alphabetically by name. So that's going to go along with our practice management files. So now our miscellaneous files, papers that do not warrant an individual folder are placed in a miscellaneous folder. So here's our word, tickler or follow-up files. They're in a chronological arrangement. The most frequently used follow-up method is a tickler file, so called because it tickles the memory that something needs to be done or followed up on a particular date. And so transitory or temporary file. The transitory file is used for materials with no permanent value. The paper may be marked with a T and destroyed when the action is completed. So we're at our closing comments. So the medical assistant should always explain any paperwork that the patient may be required to complete or sign. Take the time to explain any form that needs completion or a signature so that the patient understands the reason for collecting the information and the medical staff need to have it available. The authority to release information from the medical record lies solely with the patient unless such a release is required by law through a subpoena. Ownership of the record often is subject of controversy. The record belongs to the provider. The information belongs to the patient. And remember, let's always be willing to learn, adapt to changes, be flexible, and keep a positive attitude. The primary goal of a healthcare facility is to provide efficient, high-quality patient care. EHR systems can help the staff reach that goal, and you need to stay abreast of news and articles related to EHR systems. In the future, all providers' offices, hospitals, pharmacies, and other healthcare facilities may be able to access information in minutes, which will improve patient care and save lives. So our very last subject is legal and ethical issues. EHR system must maintain security and confidentiality of data, be easily retrievable, have safeguards against loss of information, protect patients' right to confidentiality and privacy, and require identification and authorization for access. Okay, so that is our Chapter 12 lecture. So I hope you guys learned a lot. I really enjoyed it. I'm just going to show you. I'm so proud of my notes. Look, I just made tons and tons. Well, and there's more on this other side. But I just love to make notes. And then I get in and I read and I study and I wind up making 10 pages of notes. And then when I come back around and teach it again, I just do it again. And I learn something every single time I go through it. So if you guys have any questions, let me know. See you next time.